Good evening.
Good evening. Hi, Ms. Gibbs.
Welcome, Ms. Tate Hall. Ms. Joseph, Concessa Joseph, is that a woman or a man?
Concessa Joseph, woman. Can you hear me? Can you hear me?
She's muted. She's going to be back on.
Okay, I thought she couldn't hear me. Thank you.
Mm-hmm.
Ms. Tate Hall, if you hear me, can you please say something?
Yes.
Because I see your microphone's unmuted.
Yes, it's unmuted. Okay, Miss Joseph was answering you, but then you were muted at the time.
Okay, I don't hear you. Let me switch my audio.
And can you hear me? She says she's trying to fix her window. She's not hearing us.
Ms. Tate Hall, I see you're saying something.
Can you hear me? Can you hear me? Hello?
Good evening.
Good evening.
Mm-hmm.
Good evening, Ms. Watson.
Gibbs.
Hello, guys.
Hi, can you hear me?
I hear everybody now, but I was trying to have my headphones in, but that doesn't seem to be working properly.
Okay.
I'm here, but I'm just trying to see if my headphones are going to work. But I am here.
Okay.
Hello? No, still don't hear me.
You can't hear?
Yeah, they can't hear me. Okay.
I could hear you.
You hear me now, but I was trying to plug my headphones in.
Okay.
You know, I have kids and they're loud.
Understood.
We're going to get started in a few. Good evening, Miss Watson. Miss, is that a Miss or a Mrs. Mr. or Miss Joseph from DOHMH?
Joseph, Miss.
Okay. I did want to make sure.
It's okay.
Welcome, Miss Joseph.
Thank you.
Hi, Miss Tate Hall.
Hi.
Ms. Joseph, are you representing DOHMH tonight, or are you a part of the community in Community Board 8?
I am representing DOH on the community engagement aspects.
Okay. Okay. I would like to get this meeting started pretty on time in like the next minute because we actually have a presenter coming, ladies, at 6:30. I'm gonna bring you up to speed. Anybody, Miss Joseph, would you be making a presentation tonight? Because I don't have you on the schedule for a presentation tonight.
No, I'm not presenting. I am I'm just here to just kind of connect with everyone and
Hello.
hopefully, can you hear me? Hello?
Yes, did you hear me? Okay, now I hear you.
I'm not presenting anything. I just came in to connect with everyone and hopefully to get information and give you guys an update as to what's happening on our end, and for us to possibly collaborate on some things in the future.
Oh, thank you so much. Let me put a star next to your name, Miss Joseph, because you can possibly be a later presenter. Can
Yes, we would love to.
Can caller 347 numbers ending in 08 identify themselves, please?
I'm Faye Hodge.
Excuse me?
My name is Faye Hodge.
Okay, Miss Hodge. I just wanted to make sure that we can't see your name.
Okay.
Welcome to the Health and Human Services meeting, January 20th, 2022. We want to get this meeting started. We have a presenter who will be here at 6:30. I don't want to take up any of his time with his important information.
Yeah.
A few announcements. I know I spoke with Miss Watson because she was in the email thread. We was actually scheduled to have the fire department, FDNY, here this month for our January meeting, but because of the fire that happened in the Bronx, we have been rescheduled for our February meeting. They have confirmed they apologize for not being here, but they're currently directing all of their resources as for safety and training to the Bronx because of that fire in the Bronx. So, with that being said, I want everybody to just get everybody, all their friends and their neighbors, to possibly come to attend our February meeting, which will be February. I'm sorry, calendar everywhere.
We said the 17th, but I'm gonna double check.
Yeah, I'm looking at my calendar exactly right as we said. Yeah. Yes, February 17th. Yes. Our next meeting is February 17th, 2022 at 6:15. We'll be having the FDNY fire and safety training at our meeting. We were scheduled to have it this month, but in light of the fire in the Bronx, they have rescheduled us for February. Also, we have somebody else in the room. Welcome, Mr. Langley and Mr. Mensa. Thank you for joining us today. We're just trying to move things along because we actually have a presenter coming at 6:30. Since we have a guest in the room and would like to share some information with us and possibly schedule a formal presentation with us at a later date because we don't want to cut off our current presenter this month. Ms. Joseph, can you please introduce yourself and what you would like to bring to the community CB8?
Hi, good evening, everyone. Thank you for having me. Ms. George extended an invitation for us to join, and this is the kind of partnership we've been looking for. My name is Concessa Joseph. I'm the Community Engagement Specialist at the Bureau of Brooklyn Neighborhood Health. Our offices are located at 485 Troop Avenue and also at 259 Bristol Street in Brownsville. So Troop Avenue is in Bed-Stuy. And what we've been working on many different initiatives, but focusing on COVID. And what we've been doing is, trying to keep our focus on those communities who are low in vaccination rates and testing rates. So we've been partnering with CBOs to have vaccination vans and testing vans available in different pockets of the communities, especially those who have transportation desert, where the train is far from them, or the bus is like they have to take maybe 2 buses to get there. So specifically, we started off in zip code 11233, 11213, and 11221. For the past 2 weeks, we've been working alongside Kingsborough Houses and Wicksville Heritage Center. And we've had vans out there doing testing. The numbers are going up, which is really good. We're kind of happy that community members are coming out to get tested and even to spark their interest in the vaccine. So we would love to collaborate with you guys, and for you to let us know like what areas you would like us to support you when it comes to vaccinations and testing. Also, you could schedule with me. I'll put my information in the chat, and also our director, Ms. Sharon Marshall. She's unable to make it tonight, but you could schedule with us to do PPE pickup, where you could receive the KN95 mask. You could receive the adult surgical mask, children masks, hand sanitizers. We were giving out the at-home test, but it went out really quickly. So hopefully we're gonna get a new set soon, and I could keep you updated on that. In terms of presentation in the future, we would love to, present to the community and, in about COVID or, any other health disparities you would like us to address. And just to give out the latest information and what's happening and what's not happening. I will put my information in the chat in case you have any questions. Thank you.
Thank you so much, Ms. Joseph. I just did send you information. I just sent you a request for your information. But that is definitely something we would bring to the entire community, CB8. This is a very hot topic, as you know. But yes, we will definitely be having you.
And also, we're starting to work with bodegas, school, and laundromats to address the COVID disparities.
Okay. You frozen. Okay, you're back. You was frozen for a minute. So we will be in touch, Miss Joseph. Anybody, welcome for those who just came into the room. I've seen a few people pop in as we were hearing some remarks from Miss Joseph. As I said earlier, for those who are just joining us, our presenter for January was scheduled to be FDNY as well as Kings County. Our Kings County presenter, Dr. I don't want to mispronounce this, Dr. A. Is that okay, Dr. A?
That works fine, thank you.
Okay. Dr. A is here, and I told him that I will give him the floor at 6:30. But for those who just came into the room, our January presenter was supposed to be FDNY as well. They had to divert all of their safety and training resources to the Bronx due to the recent fire. So they have actually rescheduled us to our next meeting date, which is February 17th. We will possibly also get Ms. Joseph in there, squeeze her in there as well, or somebody from DOHMH, because we're on this roll right now. And we have a lot of information out there to get to the community at large. There's a lot of information out there. So we will not be having the fire department this month. The fire department will be here on February 17th at 6:15. Any more questions before we hand the floor over to Dr. A? Seeing none and hearing none. Dr. A, we're a minute early. Thank you. Thank you, Ms. Joseph, as well. We hope you do stay. Please stay. Thank you so much, Dr. A.
Right.
You're welcome. Right on time, actually. So I appreciate that. So I was asked by Ms. Giles in the public relations office to meet with you and talk a little bit about, seems like almost everything about COVID, really, and do it all in about 15-20 minutes. So that's a daunting task, but I will try to rise to the occasion.
Thank you.
By way of introduction, I think I've met some of you already in the past, but I'm the division director in the infectious diseases section. I've been working at Kings County for 30 years now, came right after training, so I've seen a lot. I like to say that my career started during the previous pandemic, the outbreak of the AIDS epidemic and pandemic, and here I am, what I think was beginning to look like the end of my career, and it's a new pandemic. I'd like to do without pandemics, to be honest with you. So let's hope for better times. Anyway, so I'll talk for a few minutes, just sort of extemporaneously about COVID, a little bit about everything, and then we can open it up for questions and discussion, because that's probably just as important. So as you know, we're sort of in the fourth wave now of the COVID pandemic, which started in our neck of the woods in early 2020. And we had an initial surge of cases through the spring of 2020. Things mellowed out for a while. Then we had a surge of cases in the winter between 2020 and 2021. Again, it sort of played out a little bit. And in the summer of just this last year, we had the Delta wave, and now we're coping with the Omicron wave. And just for context, you know, the Spanish flu, which this is oftentimes compared to back in 1918, looked a little like this, although I have to say, sadly, it was shorter than this. And I think there were 3 waves, not 4 waves. So hopefully this might, you know, we could hope that this will be the end of sort of pandemic COVID, but I don't know. I don't want to really predict, because I haven't been right about everything about this so far, and I think it's stymied a lot of us. Anyway, so so this fourth wave has been characterized by this new strain called Omicron, and these things are just sort of randomly selected from the Greek alphabet, and that's how they get tagged with these letters. It doesn't mean anything in particular. And it's been characterized by a high rate of transmission and communicability, which is a little bit different than the previous upsurges. And it's also been characterized to a certain extent by a lack of the same level of lethality, let's say. You know, I mean, we're not seeing the same sort of apocalyptic visions that we had back in spring of 2020, when so many people were coming into the hospital, and just it was a terrible scenario. We see a lot of people having breakthrough infections, people who've been vaccinated, but they have mild infection, generally speaking. And we see people basically not needing hospitalization, or coming in and being hospitalized for a little time and then going home. I don't want to make light of it. We still see people who are quite sick getting admitted to the hospital, but again, it's not the same. It doesn't look dynamically the same as it looked in early 2020. We're coping much better with it in some ways. In other ways, we're not coping as well. I think because of the transmissibility, we're seeing a lot of staff members get sick, and that's been probably one of the more daunting aspects about this, is that we've had a lot of staff members in the healthcare sector who've come down with COVID, and whether they're really sick or not, they have to isolate. And so we've had nursing shortages, doctor shortages, transporter shortages, registrar shortages. And so, you know, with this influx of patients, we've had fewer staff members who've been able to take care of them. And that's been, I think, one of the more stressful aspects of this latest wave of cases. I will be uncharacteristically optimistic, though, and say that I think that this is playing itself out right now. And if you've been paying attention to the statistics that are put out by the City Department of Health and the State Department of Health, you know that the case rates are going down almost as quickly and rapidly as these went up in mid-December. The rates are now going down rapidly. Positivity rates in Brooklyn in the last 2 or 3 days are under 10%, which is still too high, but at its lowest level several months ago, the rates were about 1-2%, and we were all breathing a sigh of relief. And if the rates continue to drop at the clip that they're dropping right now, I don't see 1 to 2% being too far off from us now. And we're seeing this reflected in a whole lot of numbers. The Kings County census of COVID admitted patients at its height, probably around New Year's, was about 190 people. And right now it's down to around 100. That's a dramatic drop off. And just again, to sort of go back to something I said earlier and put it into a little bit of context, when we were dealing with the first wave of COVID, the patients that were being admitted to the hospital who had COVID were all sick. They were all very sick. If you look at the census of people admitted to the hospital now, in general, I would say if you take the universe of all people testing positive for COVID in the hospital, only about 50% of them probably have genuine COVID illness. The rest of them are people oftentimes being admitted for entirely different reasons who just screen positive for COVID. I can't get over the number of pregnant women who come in labor who are positive for COVID. It's stunning and striking. But they're not suffering from COVID illness, or if they have COVID illness, it's mild, you know. So again, it looks very different than it did in the spring of 2020. But that in and of itself is still a complex and daunting prospect because remember that if you have COVID and whether you're sick with COVID or not, we have to impose certain restrictions on you. We have to put you in isolation. We have to use all sorts of measures to keep you isolated from the rest of the population, whether you're sick or not with COVID. So it's another stressor on the system. So, you know, 200 COVID positive patients, even if half of them are not COVID sick, they're still stressing the system. So thankfully, again, the numbers are declining quite rapidly, and I suspect will continue to decline in the next couple of weeks. Why that's happening is itself a little bit unclear, I think. And I think part of it is that a whole lot of people are vaccinated, and so they're able to fight off this infection a lot easier, and so it's just disappearing. I think the combination of lots of people vaccinated plus a whole host of people now infected has created this phenomena of herd immunity, which we've been talking about for 2 years now. That is to say, it's population-based immunity. It's not individual immunity, but it's population-based immunity. If you have enough people in the community who are essentially immune, the virus has no place to go. And so it begins to disappear. And you can achieve herd immunity with vaccination and natural infection, but the percentage of the population be positive in this way in order to achieve herd immunity is different depending on which disease we're talking about. So for a disease like Omicron COVID, where the infectivity rate is very high, you have to have a lot of the population immune. Many of us have to either be vaccinated or infected before we achieve herd immunity. If you take another infection, let's just say flu, which spreads rapidly too, but routine seasonal flu, the reproducibility or infectivity is much lower than Omicron COVID. And so you only need a certain proportion of the population, much less than 80 or 90 or 95% of the population vaccinated or immune in order to achieve herd immunity. But at this juncture, I think we've achieved some element of herd immunity, and that's one of the reasons why this is dissipating rapidly. There's also thought given to the fact that the virus itself may have changed in other substantial ways. Not only is the transmissibility worse in some ways, but the pathogenicity, that is the ability of the virus to cause disease, seems to have been muted somewhat. And we don't know, number one, that that's entirely true. And number two, if it's true, we don't know how that's happened. There's some suspicion that the original virus was adapted well to infect lung cells, and that's how it did its damage. And that this newer strain of virus is better adapted to upper respiratory tract cells, things in the nasal passages and the oral passages, and it's less capable of infecting lung tissue. So it gives you a cold, and it allows you to spew it out effectively and infect other people, but it doesn't make you quite as sick. And there's this idea that the virus is adapting to live with us because that allows it to reproduce more effectively. The virus, this is what nature does. It wants things to reproduce, organisms to reproduce. And so if the organism is rapidly lethal and kills the host right away, it doesn't spread as rapidly. If it's a common cold virus and we can spread it to each other very quickly and easily and inadvertently, then the virus has achieved its goal of reproducibility. So in some ways, that may be something that we're looking at, but that remains to be really seen well, okay? So I'm just putting it out there and saying that we think that this may be going on. It would be nice, maybe Omicron, maybe COVID is going to become like flu, or maybe it's going to become like seasonal coronavirus. Truth be told, we as human beings have been suffering with coronaviruses forever. One of the strains of the common cold is a coronavirus, but it's different than this virus. This is a different version of that. Many animals in the animal kingdom suffer their own types of coronavirus. And what we think happened here is that one of these animal coronaviruses jumped the species barrier and landed in people and was suddenly capable of spreading in people and causing infection. And we didn't have the same level of immunity to it that we did with the seasonal coronaviruses. And that may have contributed to its spread in our population. So be that as it may, though, hopefully this trend of less pathogenic virus will continue, but we're not really sure. Stay tuned to that. Let's talk a little bit about testing. Testing is much more organized and well understood than it was 2 years ago. I don't know how familiar you are with testing. I'm sure you're familiar with having a swab stuck up your nose and rotated around a couple of times and a test being run. And that still remains the standard operating type of test, although people have been playing around with various other sorts of specimens like throat swabs, saliva specimens, those sorts of things. When we do these tests, we're actually trying to isolate real virus. Blood tests, by the way, are not about collecting coronavirus. If you have a blood test or you hear about a blood test for coronavirus, it's to look for antibodies, which is a whole nother ball of wax. If we're looking for the virus, we have to do a respiratory tract sampling. And there's two types of tests that we do in order to recover virus. One of them is called a PCR, and one of them is called an antigen test. And PCR tests are relatively new types of tests that have grown out of sort of the genetic revolution that allow us to basically rapidly multiply little bits and teeny bits of fragments of genetic material until there's sufficient amount of them that we can tag them and identify them. And it's proven to be a remarkably sensitive and effective tool for a whole lot of different sorts of infections. And these tests are, as you can imagine, they're extremely sensitive. They'll find this virus anywhere. One of the problems with the test, not to say that they're bad tests, but one of the problems you have to recognize about them is that they're so sensitive that they can pick up genes left over from dead viruses that are no longer capable of reproducing. And it's important to recognize that because simply having a positive test also doesn't mean that you're continuing to be infectious for other people. It's one of the reasons why we don't necessarily recommend that people get repeat tests done to prove that they've cleared the virus, because it's been demonstrated with this very sensitive test that you can spew little bits and fragments of virus for weeks and weeks and weeks, after you've lost reproducible virus and you mistakenly believe the person is still infectious. So we don't really base our decisions on removing isolation and quarantine based on recovery of virus at the tail end of illness. We wait for illness to go away. And at this point, we've learned enough that we know that when illness goes away, in about 10 days, that's kind of being generous even, after the onset of illness, that people are no longer infectious. So that's what we base our considerations on. We don't do repeat PCR testings because that can be erroneous information and we make bad decisions based on that. The other test that's readily available are these rapid antigen tests. And these are the basis of a lot of these home test kits that people are getting access to right now. And home test kits, these antigen tests, are not as sensitive as the PCR tests. That is to say that they can give you a full sense of security when they're negative. Now, tests are kind of, it's a sophisticated thing. The ability of a test to operate properly is dependent to a certain extent, not simply on the test, but also on the prevalence of the condition you're testing for in the community. If the prevalence is very high, the test functions better. If the prevalence is very low, the test functions worse, okay? So if you have a significantly ill person who gets tested with the antigen test and it comes back negative, that's probably a reliable result. If you have a person who's asymptomatic or mildly symptomatic or might have something else, and you test them with the antigen test and it's negative, it's not always proof positive that they don't have the virus. You have to be a little bit careful. The antigen tests are just not as sensitive as the PCR tests, but they're okay. They're a decent substitute for that. Again, in a symptomatic individual, I think it's a helpful test. So those are the two types of tests. And I mentioned again, serologic tests, blood tests. Those purely look for antibodies, not for viable virus. They can tell us if you've been exposed in the past to the virus, but can't tell you if you have active infection. They also can't tell us if you're really immune. And that's a confusing issue also. One of the things that we have failed in doing in the last 2 years is we have not determined a level of antibody or a specific type of antibody that we can measure in the blood that can tell us immune or not immune. So you can have antibody and still get infected. It's an imperfection in our testing systems. If we had a marker that could tell us immune or not immune, that would be a great leap forward, but we don't have that yet. Other infections we have that for. Hepatitis B, for example, is a case in point, but in this case, we don't have that as of yet. So don't be lulled into a full sense of security if somebody tells you they have an antibody, therefore they're immune. It's not true. So we have to be careful about that. Symptoms, pathologic disease with COVID, you probably all know it's a grab bag of symptoms, mostly respiratory stuff. You can have, nowadays with Omicron, you can have runny nose, sore throat, run down feeling, fever, headaches, very non-specific. Could be a lot of other things. Could be influenza. And we've been warned that influenza is coming down the pike and so on and so forth. And it's an interesting phenomena. In December, before Omicron hit the scene, the influenza rate started to go up in the state and in New York City. And we were all worried that we were going to see a tremendous spike of flu in conjunction with coronavirus. But if you look at the statistics, what's interesting is that as Omicron showed up and everybody put their masks back on, flu rates went right down. And we're seeing very little to no flu activity. We have to still keep an eye on that. We're still in flu season, but I think it's going to pan out a lot like it did last year, where we just don't have a flu season because everybody's isolating or wearing masks at this juncture. So, so hang on to that. There is some association of GI symptoms with bad COVID. Obviously, shortness of breath and the famous hypoxia or low oxygen levels that we saw in a lot of very sick patients. We're still seeing people with that. I've been amazed at the number of people I've seen with significant illness who have had low blood oxygen levels and don't look that bad. You know, I don't really know. I can't explain that phenomena, but it's been well recognized. But we're not seeing nearly as much of that as we used to, which is, I'm thankful for that. I will say also parenthetically, and I guess I'll get into this, that the only people that we really see in the hospital who are truly sick in that to that degree, like we used to see 2 years ago, are unvaccinated people. It's either unvaccinated people or people with serious immune conditions that don't allow them to respond properly to the vaccine. And we'll talk a little bit about that in a second. I don't know if there's anything else I wanted to say about symptoms. They're a little bit all over the map, but it's mostly, again, a flu-like illness. So that's important to recognize. I guess we should talk about vaccines, having said that. The vaccines are readily available, and I certainly think that everybody should avail themselves of vaccines. The vaccines that are available to us in the United States are two types of mRNA vaccines and an adenovirus vector vaccine. The J&J vaccine is an adenovirus vector vaccine, and Moderna and Pfizer are mRNA vaccines. And the mRNA vaccine model or platform is relatively new, but not brand new. I think it's something that put off a lot of people, but it's also the fruits of a lot of biomedical research just coming out and rewarding us after decades of work in this matter, that we were able to roll out what has amounted to a fairly effective vaccine. And I'd have to say, after a year of seeing it rolled out and given to people, a remarkably safe vaccine, I think it's a testament to remarkable work in the biomedical sphere, you know, that we were able to do this. Currently, the recommendations are certainly that people should be fully vaccinated with 2 doses of the mRNA vaccine, at least 1 dose of the J&J vaccine with a mixed alternate dose of one of the mRNA vaccines. And since several months ago, there have been recommendations for booster shots, certainly with the mRNA vaccines. And the reasons that that was recommended was that there were concerns that immunity was going to wane the further out you got from your vaccination. And in order to boost the system and boost your antibody production, you get a booster in the way that we take yearly shots for influenza. So to, again, boost the immunity. And there was some also real world data, mostly coming from Israel in the summertime, showing us that if people got boosters, they tended to have fewer illnesses, get less sick. So the current recommendations are for 2 shots of mRNA and a booster, or a shot of J&J and an mRNA additional shot. And one of the things that we've seen, and again, a lot of this stuff is laboratory-based stuff, is that, I don't know if we've frozen. Oh no, there we go. Is that the antibodies, I see you have a question. I'll get to you in a second. But the antibodies to Omicron go down significantly with the regular full vaccine panels and only get boosted up again with the boosters. So we think the boosters are important for fighting off Omicron strains, which have mutations that make them less susceptible to the antibodies. I don't know. So why don't we take your question, since you wanted to pose it?
Yeah, so I've been exposed to COVID like everyone else, probably a million times by now. But I haven't gotten sick from anything, and I've done PCRs, I've done the rapid test, and I've done the antibody test to see if I've ever been infected. And I'm a little curious to know. I mean, I'm thankful at the same time, but I'm also curious on why I haven't gotten sick from anything. Especially because I work in schools and been exposed and haven't really. Anyway, and then my other part to that question was about the testing. Like, does the test determine if you have Omicron or Delta, or is it just the symptoms that determine if you have Omicron or Delta?
Yeah, that's a good question. Let me take the second one first. In order to determine which strain you have, Delta versus Omicron, you have to do somewhat more sophisticated genetic analysis of the strain that the individual has. And at the moment, those sorts of tests are not readily available. The Department of Health will do those tests to see epidemiologically what's going on. And that's one of the ways that we knew that there was a big upsurge of Omicron back in December, and it was crowding out Delta. But that was basically epidemiologic studies, not individual case studies. Some centers that have research facilities that are capable of doing this can make this available for clinical care, I suppose. But most hospitals and most places that are doing testing right now just don't have the capability of telling you whether you have Omicron or not. So I think to a certain extent, you're right. You know, if you've been vaccinated and you get it, and I'm not saying you in particular, but you know, in general, if you've been vaccinated and then you get a mild illness, it's probably Omicron. The other thing is we can also just guess that it's probably Omicron because we know from the epidemiologic studies that 90 some odd % of the strains in New York City are Omicron. We know that from those studies. So you can just close your eyes and say Omicron, you know, that's what it is. So now the other question that you had was, why haven't you gotten sick? And I don't know, that's a good question. This is not like auto mechanics. Everybody is a little bit different. And there may be things about you that, you know, and it could be in your behaviors, it could be in your immune system, it could be previous exposures. There's some entertainment of the possibility of previous exposures to seasonal coronaviruses may have set up a situation where you had some innate immunity to these viruses. Not everybody agrees about that, but it is an interesting phenomena. You know, it's some people have not gotten sick, but we don't really know why that is. You know, I mean, lucky for you, good for you. Whatever the issue is, keep doing what you're doing. You know, but we don't really understand it completely. So I don't have much better answer than that. Now I see.
Thank you.
Yeah, sure. I see another question.
Well, good evening, Dr.
Hi.
Aldenbraun. Did I say it right?
Yeah, fine. Thank you.
I have two questions. Number one, you kind of hinted on this as far as there being distinctions in determining the differences between the Omicron and the original coronavirus, COVID-19. Oh, VARS, COVID VARS 2, I forget what the official name is.
SARS-CoV-2 to be exact.
SARS-CoV-2, right? SARS-CoV-2.
Right.
Has there ever been a picture as to an electron microscope of these viruses? What they're showing is a beach ball with a bunch of pimples.
You mean the graphic illustrations
right.
of the virus?
There's not like an electron microscope image of the virus. Why has that not been available?
You know, I don't know. I'm sure somewhere along the line I've seen some virologic imaging of this, but you know, you have me there. I don't really. It's certainly true that we don't see it on a regular basis, published in studies or even in the media. It doesn't add that much to our understanding of the virus. So I don't really have a good question why we don't see too much of that, to be honest with you.
And my second question is this. What happens with Delta variant?
What happens with what?
Delta variant. That was the bell of the ball a few months ago.
Yeah.
We hear nothing about it now. You went from the original SARS-CoV-2. SARS-CoV-2 to Delta, and poof.
It crowded it out. It crowded it out basically. The Omicron proves to be the champ. You know, its reproducibility and transmissibility makes it the winner, an evolutionary winner. Just like human beings out-muscled Neanderthals, you know, thousands and thousands of years ago. That's just the nature of evolution. So
we're saying that
I think one of the concerns is we hope that something worse doesn't muscle out Omicron.
So you're saying that worldwide, Delta is extinct?
I wouldn't say it's extinct. My guess is it's still out there, but it probably represents a fraction of the cases that we're seeing. That almost, I think the spread of Omicron has been tremendous. But there probably are still Delta infections going on.
Okay,
Does that
thank you.
answer your question?
Oh, as best you can do. But you
Okay.
know, so I
Okay.
appreciate it. Thank you.
So we were talking about the vaccine. So again, the vaccine options are sort of straightforward in the United States. People should avail themselves of the vaccine. The data. One of the things that gets debated back and forth a lot is what's better, natural immunity versus vaccination. And natural immunity in the absence of vaccine is a little bit like playing with fire. So it makes me a little bit nervous. I'm not, the other thing is natural infections are very variable. Some people have very mild infections and their immunity is not boosted that much. Some people have serious infections, their immunity is boosted a lot. And that's sort of a natural phenomena. The vaccines are much more standardized. We understand, we can expect what the immune response is going to be to that. I certainly wouldn't advise anybody to just depend on natural immunity right now. I do think natural immunity provides immunity, but in this circumstance, I'm sort of like a belt and suspenders guy. Two things to hold those pants up. Take the vaccine and your natural immunity, and you're probably pretty well covered, and you're protecting yourself from spreading the infection to other people. So that's sort of what I think. Yes. Okay. So let's go to Audrey. Audrey didn't have an opportunity to ask a question.
Thank you. My concern right now are the children, like Ms. Watson, the school-age children. Are you seeing lots of cases of children in the hospitals at this time?
Not, it's in some of the hospitals. I don't really understand the epidemiology all that well. There's certainly cases being seen in some of the hospitals. I wouldn't say in our hospitals on either side of Clarkson Avenue, we're seeing a whole lot of kids, which is good. But there are reports that children are being infected in some parts of the country. I don't understand the epidemiology all that well. Obviously children right from the get-go have suffered less than the adult population and the highly at-risk population of adults, diabetics and immunocompromised individuals. But there's still, millions of kids get infected so far in a year, and hundreds of them end up in hospitals, and a not insignificant number of children get very sick and die from this. And it's one of the reasons why the vaccines are also being promoted in children. And it's the Pfizer vaccine, I think, right now that is approved for use in kids down to the age of 5. The J&J is not approved for that purpose, nor do I think is the Moderna vaccine approved for that purpose. But the Pfizer vaccine is approved for that purpose. So, the other thing about vaccination is also to render people less infectious. And as you can imagine, and sometimes it's hard to sort of visualize these things, but we're all sort of our brother's keepers. When we get vaccinated, it's partially to protect us, but it's also partially to protect our community and other people in the community. Children are very good at, I don't need to tell you this, children are very good at spreading respiratory infections, all sorts of viral infections. I remember when I was doing my pediatric rotations as a medical student, I spent most of my time either with a cold or with diarrhea. I look back fondly on those days. But anyway, so, vaccinating kids is an effort to both, safeguard the children, but also to safeguard their grandparents in essence, because they have contact with them, and kids don't practice hygiene the way we would like them to practice hygiene. So it serves a dual purpose, I think, to get the kids vaccinated. As long as, again, we demonstrate that there's safety in these vaccines. And I think after a year and some time, these vaccines have been rolled out in lots and lots of people, and we really just are not seeing serious signals about side effects with the vaccines. It's not to say that they're entirely or perfectly safe. There's no intervention we do in any way. You know, medication is the same thing. There's always the potential for side effects, but you have to balance the good that the thing can do versus the potential harm. And I think for vaccines in general, and for these vaccines too, the benefit clearly outweighs the risk. And you know, we give lots of vaccines to kids. And by the way, I'm not a pediatrician, so you know, this is not necessarily my area of expertise. But I got my kids vaccinated. If I had grandkids, I would get them vaccinated. I don't have grandkids yet that I know about. So anyway, so there's another question.
Thank you. So my other question is, I'm in the process of getting IVF, and they told me before they can do any type of transfer, I'd have to do a COVID test, but they didn't specify if I should do a PCR or rapid, and I didn't know if you probably had recommendations behind that.
Oh, yeah, some rapid tests are PCR tests. So, you know, there's an overlap there. The rapids are not all antigen tests. Some rapids are PCR, and they're very reliable in the way the PCR tests are reliable. My guess is that you're being asked to do that in the same way that we basically ask anybody coming into a hospital for a procedure to have it done. Because we screen basically everybody. You get admitted to the hospital, we screen you because we can't let you go up into the hospital with potentially with asymptomatic COVID or mild COVID and spread it to other people. And the same thing with procedures. Even if you're coming in for a day procedure, the staff need to know whether you have COVID or not. If you have COVID, the procedure, if it's not an emergency, should be put off for some period of time. So it's not to say that there's a concern, although there would be obviously, if you had COVID and you were undergoing the procedure, let's say, but it's more for infection control in the healthcare environment. That's the reason to ask for the test. So, Audrey seems to have another question.
Yes, you mentioned about pregnant women coming into the hospital, you know, and testing positive.
Yes.
Were these women vaccinated or not vaccinated?
No, not vaccinated. And it's been my observation that a lot of them are not vaccinated. You know, thankfully, most of them are young. They're getting mild illness. One of my obstetrician colleagues joked with me and said she thought that maybe COVID was inducing labor in all these women because they were all coming in and they were having their kids and they had COVID. I don't think that that's true. I don't think we're ever going to find that that's the case, but it certainly looked a little bit like that. But I have to say, I mean, I find it a little, you know, personally, I find it a little disconcerting. You know, a pregnant woman ought to be at the top of her game about protecting her health and the health of her unborn child. And to have so many young women not vaccinated, I feel like we're losing here. You know, we're not transmitting this information effectively for people. I mean, I can understand, I suppose, and we could talk a little bit about vaccine hesitancy if you're interested. I think it's a big issue and it's something we have to grapple with. But I suppose on the other side of the coin is, you know, there are pregnant women that probably say to themselves that, you know, I don't want to get vaccinated because they're putting something in me and I have a child in me and I don't want to expose that child to that. And I can respect that and understand that, you know. But we, you know, in life, we have to make a lot of tough decisions. And this is an issue of trying to weigh out risks and benefits. And it's clear that pregnant women do worse, you know, statistically, not as bad, let's say, as an 80-year-old with diabetes and hypertension, or a transplant patient. But the data are pretty clear that to be pregnant and to have COVID is not a good combination. You can get sick. And we shouldn't do that, you know. But we've had this issue with flu too in the past. A lot of pregnant women, season after season, you try to urge them to get flu vaccine because, again, the data suggests that flu and pregnancy is a bad combination too. And people don't avail themselves of that. So I feel like, you know, that's an area that we really have to work on. So, but yeah, it's impressive how few of them are vaccinated. So yes, question.
Is there any? Oh, sorry.
Go ahead. Go ahead. Go ahead, Ms. Watson.
Is there any research on if a woman is pregnant and let's say she gets COVID, like can it transfer to the baby in utero, or
No,
we don't know?
no,
No? Okay.
no. It's not transmitted that way. Not transmitted. Yes, yes.
Yes, I'm glad you touched on that topic. When I was with child, my daughter is now 8. I caught the flu virus. I cried in my OB's office because she could not give me the flu vaccination because I was high risk because I was 36.
Mm.
And since then, I've gotten the flu shot. I've never had the flu prior to that, and I literally stopped taking the flu vaccination 8 years prior to that because my job had changed and my risk of catching the flu had decreased dramatically. But my dad was I couldn't get a flu shot because I was with child. What do you? I think that's a lot of the concern with pregnant who are with children or possibly at the crossroads of having children, where they tell you can't take no medication while you're pregnant, can't take Tylenol, but then you want to take a flu shot. So what would you tell a pregnant woman or someone who's looking to have children?
Yeah, I mean, that's a good point. That's mixed messages for people. Don't take any medicine whatsoever. Although, of course, we know that some medicines are perfectly safe in pregnancy. And then at the same time, we say take a vaccination. They're not quite equivalent. The vaccine and a medication. The vaccine is we wouldn't give. Let me take a step back. So, there are different types of vaccine, right? So there are some vaccines that are live virus vaccine and some that are, recombinant vaccines. And we certainly don't give live virus vaccines to pregnant women because we don't want to give them some replicative organism that obviously nobody would feel comfortable with. There would be too far a risk for that. But to give somebody a recombinant material that doesn't survive in the body very long, again, to goose the immune system, is to take nature's way almost, is to say, to the immune system, here it is, this is the way you develop immunity anyway to all sorts of things. You get an infection, you get immune. It's sort of the same thing. It's not like taking a medicine that, for example, that passes through the placenta and may cause harm to the baby. It's an immune phenomena. And it's felt that in and of itself is a relatively safe thing. Now, again, how you get that through to patients when you told them all this other stuff, that's an art, I mean, that's, maybe we don't talk to people that well anymore. That's the other thing, is I think another part of the problem, I think, just to wax poetic on this a little bit, is that I think the healthcare system has let people down. I feel like people don't have good relations with a doctor anymore. It's like, who do you turn to for information? Years ago, you would go to your doctor and that would be the font of information. It would be your trustworthy source in the community. And now we have very shoddy relations with our healthcare providers, very perfunctory relations. And we get a lot of information from really, bad sources such as the internet and various other things. And I think that's to our disadvantage. If I had to recreate a system, I would try to make sure that everybody had a personal physician that they could turn to as a source of information. But I don't sort of have that power, I think. So maybe in an ideal world someday. I know it's getting late. I don't want to, I know everybody has something to do. I just want to talk a little bit more about therapies, because I'm sure you have some questions or some thoughts or ideas about therapies too. 2 years ago, we didn't really have treatments of any sort for this. We've had the introduction of several therapies. Some of them are for people who are quite sick, and some of them are for people who are not quite sick. There's nothing really that well in the middle. The stuff for people who are quite sick doesn't work that great, I have to say, still. And you may have heard the names of some of these drugs: Remdesseviere, dexamethasone, things like anti-inflammatory drugs like tocilizumab or baricitinib. I can't even pronounce some of these things. their efforts to sort of tamp down this ultra aggressive immune reaction that develops on the tail end of a COVID infection, and they don't work that well. So really the trick is to try to keep people from getting to that point, to try to attack the virus in the earliest stages. And we have some therapies right now. One of them is monoclonal antibodies, which I'm sure you've heard about. The one that is available commercially right now that's active against Omicron, and we've had several of these products available over the last year, but there's only one that's really active against Omicron. It's called Citroevumab, and it's a one-time infusion, and it's basically antibodies. It's giving you antibodies, giving you monoclonal antibodies. So instead of me vaccinating you and you making the antibodies, I'm giving you the antibodies that have been developed in the laboratory. And it's shown that if you can give that to people in the earliest stages of illness, you can halt the progression of illness, but you have to get it in there very early. And we're reserving that sort of treatment for the people who are at the highest risk of complications. And that includes the elderly, people with diabetes, hypertension, serious cardiovascular disease, pulmonary disease, immunosuppressed individuals, transplant cases, people with lupus. I could go on and on. It's a long list of people who should be at the front of the line for that. And that's fairly effective, and it's safe. We've been using immune globulin products in patients for years for a whole wide range of things, and people tolerate it fine. There's a new monoclonal type antibody product called Evosheld, which is being used and referred for what's called pre-exposure prophylaxis. And that means for people who we suspect won't be able to mount a response to vaccine, for example, people who are on heavy-duty cancer chemotherapy, or people who are transplants getting immune suppressive therapies, who even if you vaccinate them don't have a really robust response, we can give them this immune globulin preparation. And apparently it's been tweaked so that it has a 6-month half-life. So it basically is passive immunity, protecting the individual almost like they got it vaccinated for 6 months. And so that's the group that it's recommended for. There's some concern about higher risk of cardiac complications in people who have pre-existing cardiac disease with that product, and it's giving some people a little bit of pause in using it. But I think in a well-chosen individual, it could be very, very helpful. I mentioned Remdesseviere, which we've been using for people who are quite sick. Remdesseviere is a antiviral drug that's given intravenously. There's recently been the publication of a paper that shows that if you can catch somebody very early on in disease and give them 3 consecutive days of an infusion of Remdesseviere, you can halt the progression of the illness. Sort of like the monoclonal antibody, early treatment, halt progression. The problem with the Remdesseviere 3 days is you have to give it 3 days. So that means you have, we select outpatients mostly with mild disease. So somebody's got to come to the hospital day 1, day 2, day 3 and get an infusion. We're not really set up to do that well. The Citroevumab is easier. You give it once and you're done, So we can do an infusion in an infusion center like that. The other thing in terms of therapies to be aware of, there are 2 new oral therapies. One is called Paxlovid, and the other one is Monoclonal and the Paxlovid and the mono drug are both basically the same in terms of having to be administered very early on. They're antiviral medications. The Monoclonal drug doesn't work as well as the Paxlovid. Paxlovid works much better. So most of us would prefer to use the Paxlovid. There are some supply issues right now, but it's supposed to get better. You have to take it for a few days. You could take it at home. It is a combination of drugs that's very similar to medications we've been using for HIV treatment. Which is, it makes sense. COVID is an RNA virus and HIV is an RNA virus. So why not? So And it seems to, again, sort of halt the progression of infection, but we don't have a lot of experience in the community with that as of yet. So that's really, those are the therapies that are available to us right now. So it's better than it was 2 years ago. It's still a little bit operationally daunting, but it's better than it was 2 years ago. Hopefully we will see progressive declines in the case rates as they seem to be doing right now. And we don't get sucker punched by another strain coming out in the community and requiring all these interventions. And maybe we won't have to do all this stuff, you know, in the future. I sort of suspect the virus is going to be with us for a while. And we will see people continue, even if it goes away as a population-based problem, we're still going to see at-risk individuals show up with bad illness, bad respiratory illness. Hopefully we'll have better therapies, maybe better vaccines as we tweak the vaccines to adapt to these new strains. So I think there's cause for optimism, but boy, it's been a tough 2 years, you know. I think one of the problems in the hospital is everybody's just, not only is there staffing issues, but everybody's exhausted. And that really concerns me. You know, you have exhausted staff and understaffing, and it's a recipe for other problems. And the public's exhausted, and people haven't accessed medical care for other things, for their diabetes care, for their cancer care, so on and so forth. So we really, you know, we have a lot of work ahead of us. So I don't know, spring can't come too soon, I think. So anyway, that's about all I have to say. I don't know if there are any other questions. Yes, ma'am.
You think this we have to continue to take shots of the virus going forward?
The vaccine, you mean?
Yes.
Yeah, I don't know. You mean like I think a lot of people wonder whether we're going to have to do like with this, like we do with flu every year, vaccinate. I don't know. You know, I sort of in the back of my mind, I think that the technology is getting to the point where we're probably almost maybe going to do away with yearly flu vaccines, you know, because the technology is getting so good. And maybe that'll be the case here. If we can find the Achilles heel of this virus that's present in all the strains, and there's reason to believe that that's doable, then you could take one shot and the immunity ought to persist. And you know, the other thing is when we talk about immunity, we talk about antibodies and vaccines producing antibodies. That's not the be all and end all of your immune system. Your immune system is extremely complicated, has many different players like members of an orchestra. And there's reason to believe that some of these stay primed for a long time. So I'd like to, again, be optimistic and think that we're not going to need that, but I don't have a crystal ball, and I'd be mistaken to tell you that we're definitely not going to need that. So I hope that's an adequate answer for you. And Audrey has another question.
You were talking about the flu. I don't remember if I read it or I saw it, but are there two kinds of flu injections, one for the average, you know, person,
Yeah.
and one for seniors?
Yeah, well, yeah, I know what you're talking about. There is there's a high dose and a standard dose. That's what it is. It's not like it's two different preparations. It's the material, the antigenic material, the thing that stimulates the immune system is sort of double dose for older folks. That and it's been demonstrated, you know, because you get older, like a lot of things don't work that well anymore, right? Your memory's not the same. You can't run up the stairs as quickly as you used to. You know, things don't work as well. The immune system is the same thing. It doesn't work quite as well. So you take a standard vaccine and you don't make enough antibodies. And it's been demonstrated both in the lab and clinically in populations that if you double up the dose of antigenic material for a senior population, now I'm talking about, that the protection level is better. And so I certainly would recommend that people with, you know, complex medical problems and certainly over 65, maybe over 60, the CDC has recommendations around this, that they probably should avail themselves of the high dose vaccine. I think that's a good idea. and it's readily available.
Thank you.
Yeah, for me, they have to give me the senior one because I'm in my 70s. So they have to give me the one for the seniors.
Does it hurt?
I did go and they said, oh, we don't have it for your age. So I had to go back.
Yeah, I mean, I would guess that some places don't stock it as readily as other places, but you can find it. There's no doubt about that. It's
Oh yes, I found that I took my
I mean, one concern about it is that it has so much antigenic material is that you may have more of a reaction, like how you get a reaction after a vaccine, your arm hurts, you get a little bit feverish, you feel kind of weak for 24 hours. There's some concern that may come with that package, but that's the price you pay, 24 hours of feeling a little bit lousy in order not to get rip-roaring influenza sounds like, again, a decent deal to me.
And for me, that's the reaction I got taking the regular flu shot. And I decided I'm not dealing with this anymore.
You're not getting the flu shots.
No.
All right.
I
I
did
mean, you have to make your own decision. I certainly, people make those decisions, and we have to be respectful of that. I think that the COVID issue sort of, personally, is a little bit different because the consequences that we've seen have been so severe. This is really amounts to a public health emergency. But I feel like, again, we are all our brothers and sisters keepers, and we have to do everything we can to keep the community safe. So in other circumstances, maybe we have the luxury of making personal decisions. Here, I think that's less clear. The vaccine hesitancy thing, which I said I was going to talk a little bit about, is, again, very daunting. It's old. I mean, it's not something that developed as a result of COVID. It's been existing since Edward Jenner first introduced smallpox vaccination 200 or 300 years ago. And I think there's a complex web of things that make people very hesitant about vaccines. People don't like the government telling them what to do, number one. Number two, the mere idea of putting a live thing in you or something of a live thing sort of rubs people the wrong way. And so we have to deal with that. I don't know. That's our challenge. It's not gonna go away. So. Okay, I hope everybody's had dinner already. It's getting late.
Are there any final questions for Dr. Argenbron? All right, so I'll take that silence as a no, and I just want to thank everyone for coming out today.
Hello,
hi.
sorry.
Okay.
Hi, I'm Keisha. I work with Dr. Argenbron at the hospital. Good evening, everyone.
Good evening, Ms. Giles.
Keisha.
Hi, Dr. Argenbron. I actually have a question. So over the Christmas break, I actually had COVID. And as you know,
I hope you feel better.
I do. I can honestly say that I think that the vaccine helped because my symptoms were really very mild. I had a bad headache and I just had cold symptoms. And what actually prompted me to get tested is because I was having a little bit of shortness of breath and I thought that was a little unusual. And because I know that that's one of the symptoms, it prompted me to, and obviously I work in a hospital, I wanted to get tested and I'm glad that I did so that I was able to isolate and protect my family, my husband and my son. So OHS has informed me that when you have COVID, and Dr. Argenbron, you touched on it a little during your presentation, that it's futile to get tested again, to see if you're in the clear. And it actually takes 30 days for you to yield a negative test after you've tested positive for COVID. My concern is, and my question for you is, during this time period where if I do get tested again, it's going to be positive, how do I know that during this interim, how do I know if I do have COVID again?
Yeah.
If I.
Yeah, that's a good question. You can't really know, except the studies have demonstrated to us that if you've recovered in a sufficient amount of time, and like I'm saying, about 10 days or so since the onset of illness, that we don't have a phenomena of people sort of you know, like a Trojan horse harboring replicative virus anymore. We just don't, you know, we have lots of data to show us that that doesn't exist. That if you've gotten better, that that's gone, and that any positive test is just, it's garbage. You know, it's viral garbage that still little bits and pieces that are still floating around. There are actually ways in the laboratory to even look at that at a finer point and this gets into a technical issue. The machine has to cycle a certain number of times to multiply the genetic material. You may have seen something about this in the press, and that the more times it has to cycle, that means that there's less and less virus in there. And there's been people who've shown that once you get up above a certain cycle threshold, there's never been identification of replicative virus. But that test is not generally available for us to make clinical decisions. I would say if you're better, if you've gotten better, you had COVID, the requisite 10 days have passed, don't get tested for COVID. It's just going to make you crazy. If you happen to get retested, that virus is, you come to me, I'll write you a note. I'll say, you don't have replicative virus. Don't worry about this woman. She can come back to work. Don't think you're going to get her to work on that.
Thanks, Dr. Augenbraun.
Okay.
Okay, so before we close out our meeting, are there any final questions for Dr. Augenbraun or for Ms. Concessa from DOH?
I just want to clarify for next month. My guess, we talking about sickle cell. Is that still on the schedule? Next month meeting?
I believe we're doing that for March. Next month, we're going to do our fire safety meeting that got pushed back from this month due to the fire in the Bronx. And the FDA line needed to redirect their resources there.
Okay.
Yeah. So on that note, a round of applause for Dr. Augenbraun. This was really amazing. Our community really appreciate the time that you took out to give us such an informative and amazing presentation. And I just wanted to know if we had any more questions. Should we be reaching out to Ms. Giles if people in the community wanted more information or resources?
I'm around and available. I'm happy to talk to people. It's part of my mission and job, you know, to talk to people. So, you know, if you have a venue where you think I can be helpful, just let Keisha know and we can work something out.
Thank you for that. And on that note, I just want to remind everyone that next month's meeting is on February 17th at 6:15 p.m. And we will have our fire safety presentation and training by the FDNY. And on that note, thank you all for coming out and have a wonderful night.
Stay safe, all.
Good night.
Bye.